It's Healthcare Unfiltered, and we have a celebrity in the house. It's his first time. So, Anthony, if things get better after this podcast, I'll take credit. If they get worse, I'm not going to take any of the blame. Welcome to the show.
Thank you for having me, and I'm happy to give you all the credit if things get better after this.
So I've asked you to come on. I know how busy you are, and it took a while to finally align on a time. So I really appreciate it because I really wanted to chat a little bit more on healthcare policy, Medicaid, and frankly, I was inspired by your argumentative behavior on X, which we will discuss in a few minutes. But let's start by getting to know you a little bit. Tell us about you and what you do and where you work and so on.
Sure. So I'm a neurosurgeon. I work at a University of California, San Francisco. Of course, all my views expressed here are my own and don't represent my institution. Um, but I work primarily out of our safety net hospital, San Francisco General Hospital. I subspecialize in neurotrauma and spinal cord injury. And I've worked at safety net institutions my entire career. I trained down in New Orleans at Louisiana State University. And our main hospital there was Charity Hospital, which was a huge safety net facility, covered much of Louisiana. And because of that, I've taken an interest in healthcare policy and specifically financing the safety net. So Medicaid, and other safety net mechanisms for financing to ensure that we do have access to care for the people who need it the most. The more I got interested in healthcare policy, I was able to get a master's in healthcare administration down at LSU and spent some time with Senator Bill Cassidy in DC, where I could really kind of learn some of the nuts and bolts. And since coming to UCSF, I have been a member of the Institute for Health Policy Studies here as one of the core faculty members there.
Amazing, amazing. You have not only you're able to practice, but your background really gives you significant insight into policy and how some of the laws get passed. What got you into neurosurgery?
I wanted neurosurgery basically since I was a kid. I suffered from terrible migraines, and because of that, I took an interest in the brain and neurosciences. And then the more I learned about medicine, you got into med school and loved the anatomy lab, loved working with my hands. And so I realized neurosurgery was the right route for me. I wanted to pick a nice, easy subspecialty
Yeah,
too,
it's
one with
I mean,
a
I
lot
could
of
have done it. I do it in
work-life
my sleep.
balance.
I could do it in my
Yeah,
sleep, frankly.
exactly.
I mean, it's very simple. But is it true that, I mean, are there stats about the like how few neurosurgeons out there per capita or per patients? Like, what's the stats? Because we hear a lot about shortage of doctors, shortage of oncologists, and what's the stats of neurosurgery?
Yeah, I tend to think that there's more distribution effects rather than true shortages. However, I think in the overall physician workforce, we're certainly seeing some shortages, but it's more on the back end. I think a lot of the changes that have happened to healthcare recently is are promoting early retirement in physicians. And I think we're seeing that in neurosurgery as well. It's just that there's too much paperwork, too much bureaucracy, declining reimbursements, so people are getting out when they can. So if there is a little bit of a lack of physicians or lack of neurosurgeons, I think it's more that because people are electing for early retirement or early exit from the practice of medicine.
And did your interest in kind of healthcare policy stem from when you went back to your master's, or was it more when you started working for Bill Cassidy?
It was even before that. It was, from intern year, step one, just getting into the hospital and realizing, hey, 90% of what I do has nothing to do with patient care. Why am I checking so many boxes in the EHR? Why do I have to fill out so much paperwork? And it was just this desire to figure out why things are running the way they are, and that just kind of snowballed into this love for healthcare policy and I really took up a love for economics as well because I think a lot of the reasons things work the way they do have a lot of economic undertones. And so I've read a lot of sort of the Austrian economics, Hayek, Mises, Sowell, Friedman type economics, and that's really influenced a lot of my thinking on policy as well.
Brilliant. I am going to do a podcast on Austrian economics. It comes up a lot. Our colleague Anish Koka, who probably is listening to this, if not, he's in trouble. But his interest, I believe, in healthcare policy, he told me, stems from the CAC, Affordable Care Act, ACA, when he started just having the impact on his practice, and then he became interested. Like there's always, I always feel there's like an event or a catalyst situation that leads people to want to investigate further and so on. So it's interesting that for you, it started actually much, much earlier. So the topic I wanted to discuss with you is specifically Medicaid, public aid, and I don't think there's anyone better than you to help us understand it just because of where you work also in a safety net hospital and so on. So let's start by just understanding who qualifies for Medicaid and from there, I guess the pluses and the minuses of the Medicaid system as a structure to provide coverage for folks.
Of course. So Medicaid was passed the same time as Medicare, 1965. And Medicare and Medicaid were both passed essentially to provide healthcare coverage for people who didn't have employer-based insurance because of the way healthcare sort of emerged or health insurance emerged naturally out of the market. It covered a lot of people who had jobs, but not people who didn't have jobs. And so Medicare was created to cover seniors who had retired, no longer had coverage through their employer. And Medicaid was created to cover other specific groups that could not get health insurance coverage through their employer. So the original Medicaid beneficiaries were the elderly disabled, or excuse me, the elderly poor, the disabled, the poor children, and poor pregnant women. That was the original Medicaid beneficiaries. Medicaid was created as a federal state partnership. And so the federal government pays a portion of the cost, but most of the costs are borne by the states. And the amount the federal government reimburses is called the FMAP, for the federal matching percentage. And the FMAP is calculated based on the per capita income of the state. So poorer states have more of their Medicaid expenditures reimbursed by the federal government than richer states. And it varies between about 40 to 60% for the original patient populations, the original beneficiaries. States have some liberty to operate their Medicaid programs as they see fit. There are certain waivers they can apply for through the federal government where they can cover additional populations or move funding around in different ways or try different, sort of natural experiments. And this is one of the things I love as sort of a classical liberal economic theory is that Medicaid has more local control than Medicare because Medicare is one blanket policy for the entire U.S., where Medicaid has this state-based feature to it, which I think is a feature, not a bug. I really like that states can kind of tailor it. With the passage of the Affordable Care Act, states had the option to expand Medicaid to healthy, able-bodied poor, anyone up to 138% of the federal poverty level could be eligible for Medicaid with the Affordable Care Act. And notably, many states have opted into that. Most states have. A few states have decided to still hold out and not expand Medicaid. But when that was passed, that ACA expansion population is actually covered 90% by the federal government and only 10% by the states. And that was part of the sort of the nuance behind the ACA is this FMAP differential, what they call it. And so what you have is states that enroll healthy, able-bodied, low-income individuals get 90% of those costs reimbursed, whereas the original Medicaid beneficiaries only have that 40 to 60% of costs reimbursed. So there's a little bit of a differential there. And with these waiver programs, states have taken it even further and enrolled more and more people into their Medicaid programs that aren't actually mandated by the federal government. There's a recent paper put out by the Manhattan Institute where they looked at the amount of spending in Medicaid and saw that of all the spending in Medicaid, about 63% is for these optional groups. About 22% of that is for the ACA expansion population, and another about 41% of the spending of Medicaid is for groups that aren't even mandated under the original Medicaid law or under the ACA expansion. These extra groups that, for example, here in California, there's ways that people up to 400% of the poverty level can qualify for Medicaid. There's other groups that, such as undocumented immigrants, who aren't technically supposed to be eligible for Medicaid under federal law, but are covered in states like California and New
So,
York
so
and various others.
each state does their own law, essentially, of who they are willing to cover and not to cover, but that decision impacts how much federal assistance they get.
Exactly. And so these decisions have to go through a CMS waiver. So if California wants to expand Medicaid to a certain population, they do have to put forth a waiver to the federal government that has to be approved or denied. But once that waiver is passed, this patient population does draw down federal dollars. So even covering things such as undocumented immigrants, the state does use various financing mechanisms to have a lot of that covered by federal dollars. So with more and more of the costs being covered by the federal government, states do not have the eligibility. They're not as tight with the eligibility rules as they otherwise might be if they were on the hook for greater costs. And that's sort of what's led to this ballooning of Medicaid. In California, it covers about 40% of our population now. In New York, it's something like 44% of New Yorkers are on Medicaid. And so if we take a step back and think, what is Medicaid supposed to be? It's supposed to be a safety net program. Think of those original beneficiary populations. Those are the ones that Medicaid was designed to serve. And what we have is we have a bit of a crowding out effect. Because Medicaid tends to reimburse pretty low, you don't have a whole lot of providers that are willing to open up appointment slots for Medicaid patients. And because of that, you get this crowding out effect where if you add more and more people to the Medicaid pool, there's fewer appointment slots to go around. And you do see the original patient populations, those original safety net populations, are a little bit crowded out. It's harder and harder for them to get services through Medicaid because you've added more and more people to the population.
I mean, is this, I mean, okay, 10 years ago, do you think more physicians and practices were providing care for Medicaid and then they made the decision not to do that because of reimbursement?
I think it's been pretty consistent. And again, different states, a feature of Medicaid that I like is that different states can set their reimbursement levels differently. So there are some states where you can get pretty good reimbursement for Medicaid patients. And those patients in those states don't have the access to care issues that you have in other states where Medicaid reimburses really low. And states go in and out, largely depends on state budgets. There's other financing mechanisms such as state-directed payments where they can kind of funnel some of the funds to things like rural hospitals or to service lines that are traditionally underpaid to keep access there. But a lot of it comes down to political decision making on the state and local level, which again,
Mm.
I think is a feature and not necessarily a bug of the program.
Okay. In general, you, Anthony, you are okay with the Medicaid program as it started. You're against, or at least you're not in favor of the expansion. Is that a good framing of your position?
Well, I think I'm in favor of having a robust safety net. I think those of us with the more kind of free market ideals or libertarian ideals tend to forget that there's a distinct safety net that really won't be able to participate in the free market, no matter how much you try to subsidize it or things like that. For example, I deal with neurotrauma in San Francisco. I have a lot of patients who have substance abuse problems, mental health problems. No amount of subsidies or libertarian economic ideals are going to get those people the coverage that they need. So I think we do need a robust safety net for people who cannot participate in the market. And I think for those that don't have the means to participate in the market but otherwise could, I think straight up subsidies, general subsidies, would do them better than a government run program. And so I really think if you look at, say, the able-bodied poor, I think they're much better off in a commercial market. And if they don't have the finances to get into the commercial market, we should just subsidize it so that they can enter the commercial market where the reimbursement rates are better for the physicians, where they
How
have
could
much
you
better
but
access to
how could
care.
you but sorry to interrupt, Anthony, but
Yeah, of course.
how do you subsidize it in the commercial market? Because if I'm like, I mean, what I'm hearing you're saying is that you don't need the government program. You could potentially just go into commercial payers and
Right.
do the free market thing. But these folks unlikely to afford any of that, no?
Yeah, well, so the average ACA beneficiary costs about $6,500 or $7,000 per year for the combined state and federal expenditures on the average. This is the average ACA expenditure, ACA expansion Medicaid beneficiary. So, say $7,000 a year that we're spending on them. You could give a $7,000 a year subsidy, and they could use pretty much afford uh, probably a lot better coverage than they're getting through Medicaid. Right, for
I
a
see.
healthy 35-year-old, right? Their annual expenditure is going to be pretty low. You could even do things like put that $7,000, put half of it to cover a catastrophic plan and put the other half in an HSA. Just give them fund their HSA for them so they have control over their own healthcare spending. They can build wealth over time. By the time they retire, that's a healthy, substantial HSA fund that they could draw down from in retirement, and it, motivates them to stay healthy, et cetera. So by transforming that Medicaid benefit into some sort of premium assistance or HSA contribution and really leave it up to the beneficiary to decide what is best for them, I think that gives them a lot more flexibility. It gives them a lot more control over their own healthcare. It gives them a lot more, frankly, lets them enter the commercial market and get the same care that you or I were to get, and exiting this government-run program.
So for those who are listening, what you're proposing, at least one solution. Well, first we have to identify the problem, right, before we form a solution. But let me start from the solution is if we're paying $7,000 for a Medicaid beneficiary, give that money to the beneficiary and let them decide what to do with it.
Yeah,
That's in a nutshell.
yeah, exactly.
And the problem with Medicaid, if we have to outline the problem, I know one problem, which is obviously not, it's very difficult, honestly, to find a neurosurgeon like yourself who might be willing to take a Medicaid patient in the free market or in private practice, I guess. Um, Other problems with Medicaid, aside from access to the right care, is that the biggest issue?
Yeah, I think the biggest issue is access to care just because of the reimbursement rates. And I don't begrudge my colleagues who don't take Medicaid, right? They got to pay the bills, they got to pay to keep the lights on and pay their staff. And if Medicaid is paying 10 cents on the dollar compared to commercial insurance, of course you're not going to open up a lot of clinic spots to see Medicaid patients.
So, I want to talk about some of the reforms happening now. Now that we understand the problem, we understand part of the solution you're offering. Over the past several weeks, you got into a Twitter feud into what you're offering and some other folks who were contesting this. And I was just observing this back and forth, and then it just like took so much time because you guys don't give up. So what was the issue? Why were people really um, not happy, I guess, with your statements?
So some of the reforms that are being considered for Medicaid are largely around eligibility verification. All right. And so as we're talking about Medicaid, I mentioned that the states are not on the hook for as much of the funding as the federal government is now, but the states still control the eligibility. And then if you look even closer on the local level, most states actually use what are called managed care organizations to administer the Medicaid benefit. And what that means is the managed care organization gets a per member per month check from the state. So the more people it has enrolled, the more money it gets from the state. And
Right.
because states are a little bit loose with eligibility verification, there is ample evidence that there might be people enrolled in multiple states, or there's people enrolled in Medicaid who have private insurance, or there's people enrolled in Medicaid who have died. But these people have the eligibility checks are not there to ensure that the state isn't still paying a check every month for to this MCO for it covering this beneficiary. Now, I'm in general, I'm a big fan of MCOs. I think managed care has done a lot to keep costs down, but you have to have pretty strict eligibility checks to make sure that the MCO is not getting extra money for patients who are no longer eligible. So a lot of what the reforms are being talked about do is increase the eligibility verification from every year to every 6 months. It also does things like institutes a work requirement for not for the entire Medicaid population, but for that able-bodied poor, that expansion population. It institutes a work requirement so that they have to do 20 hours a week of things like community service
Hmm.
or education or job training or work in order to maintain that Medicaid benefit if you are an able-bodied poor individual. But I think that sort of functions as an additional eligibility check for a lot of these beneficiaries.
Was that the issue? Like people were kind of like upset with you because you're demanding more checks and balances? Like it seems to me like a reasonable request. You're not asking something that should be that controversial.
Yeah, I think a lot of it has to do with, it seems like there's a certain segment of the vocal healthcare policy space that thinks that any reduction in the total of Medicaid beneficiaries is a failure. I look at inflation of Medicaid as a failure, right? Why are we putting
Yeah,
people on a program that really doesn't work? A program that was designed as a safety net program. I mean, we wouldn't be celebrating more people on Section 8 housing or on SNAP, right? We want to
right.
get people off of these programs and so that they can take care of themselves, they can have individual responsibility, individual control over their own their own healthcare spending. We don't want people perpetually on these safety net programs. Again, there's a large proportion of the population in Medicaid that will never be able to participate in commercial markets. So let's focus Medicaid on them, make Medicaid work for those patients, and not necessarily make it work for this expansion population, able-bodied, poor, et cetera. If we get them more on the commercial market or give them the means to eventually make out of the Medicaid system, I think that that's a good policy win. But there are certain people who consider Medicaid a social good, right? They look at things like the cost sharing. There's no cost sharing in Medicaid, right? You don't have premiums, you don't have copays. And so they look at that as a good thing because they think that that is going to get people to utilize healthcare services more. And there is some argument to that. I tend to not agree that that zero cost sharing necessarily improves healthcare outcomes. I think there's pretty ample data that it doesn't. But there are people that are pretty committed to the fact that people that there should have essentially free healthcare. And what I've seen in states like California and New York is, there's no political will to pass what we would consider a public option. But administratively, they've sort of expanded Medicaid to become sort of a de facto public option. And if you want to have a de facto public option, I don't think that's the right way to go about it. I think we should have that discussion politically. And if we want to pass a public option, we pass a public option. I'm not in favor of a public option, but people have essentially turned Medicaid into this public option without going through the appropriate democratic process.
Well, speaking of passing things, I mean, there's a bill that, I mean, we're tipping this just for context for folks who are listening and viewing this. It's June 4th, I believe, 4th,
Yeah. Yep.
2025. And my understanding, there's like a big, beautiful bill happening. So by the time
There
this
is.
airs, maybe it's passed, not passed. Is the Medicaid situation part of this bill that's being considered in front of Congress?
Yes, it is. So they have about $800 billion worth of savings in the so-called Big Beautiful Bill that have come from reforms to the Medicaid program. And so as we spoke about, a lot of it is these eligibility verifications and the work requirement. And again, I think that's mostly going to affect, it's going to decrease the overall numbers of people in Medicaid, but I don't see a lot of people that who legitimately need the program will be losing coverage. If you lose, a certain number of people because they shouldn't be enrolled in Medicaid because they actually have private insurance or duplicated in two states, then that's not really a coverage loss. That's just a decrease in the number of people who are on the ledger. Um, so I think a lot of the savings will come from that. It does do other things, like it will penalize states who continue to offer Medicaid services to undocumented immigrants. And it does some adjustments to these things called provider taxes, which is one financing mechanism that the states can use to essentially draw down more federal funding.
I think, Anthony, one of the things that is intriguing to me is states obviously have a lot of power here, but they make a decision of what is the minimum income, for example, required to be eligible. Like you said, in California is different than probably New York or Chicago, where I am. But with that, I can appreciate the folks who are the original 1965, the original folks are really need Medicaid because they're unfortunate. I also appreciate the fact there are some folks who trick the system and they probably have commercial, all that stuff. But there's those in between where you're not very poor to
Right.
get the Medicaid. You're not really tricking the system. You're not very rich to get commercial, but you're in the
Yeah.
middle. And I think help me understand for these folks, are these the reason why folks are trying to expand Medicaid? Because unfortunately, cost is getting more, they're not making more, they're really normal citizens, not skimming anyone, but they could be making, I don't know, $45,000 a year or $50,000 a year, and that's just not enough.
Yeah, and I totally agree with you. And I think you hit on one key point there is that costs are rising. Why are healthcare costs continuing to go up? Right? The Affordable Care Act turned out to not be affordable. It accelerated the consolidation that we see in healthcare. And one of the reasons why healthcare is so expensive, there's ample economic data on this, is that large hospital systems have been consolidating. They've been buying up independent clinics. They've been buying up independent hospitals. And when they consolidate, they raise prices. When they raise prices, that directly affects how much you pay for your health insurance premium. The ACA also did things like it made cheap catastrophic healthcare plans illegal. So you have to buy a healthcare plan that covers, preventative care and birth control, XYZ. So there's mandatory minimums for your insurance coverage, which makes insurance more expensive. So hospitals are consolidating, they're raising prices. Those prices are reflected in higher insurance premiums on top of the fact that we've essentially outlawed cheaper insurance alternatives like catastrophic plans. So if we want to make healthcare more affordable, instead of expanding a government-run program to take care of those people who, like you mentioned, make $50,000 a year and can't afford health insurance premiums at their current level, why aren't we talking about the cost drivers? Why is healthcare so expensive? So in addition to reforming Medicaid, we need to be looking at reforming why healthcare is so expensive, taking care of these large hospital monopolies that are raising prices that are reflected in the higher insurance premiums, and take down the prices for everyone. Because if we lower the price for all, then more people can afford that healthcare benefit. So it's not going to be a huge burden on that person who's making $45,000 a year. Or if we decide we want to subsidize that person, the subsidy that we have to give them to get adequate coverage for their needs would be a lot less.
So let me ask you this, since we're talking about cost and lowering prices, the Inflation Reduction Act is a law that allows government, obviously, to negotiate drug prices. Where you are right now, are you in favor? Do you think this is a good thing? Because we can argue it both ways, but essentially, it's like an Inflation Reduction Act is trying to lower costs, or do you not think so?
I'm not a fan of the Inflation Reduction Act for two reasons. One, I think on the larger scale, I know we pay a lot more in the U.S. for list prices. Our list prices are a lot more in the U.S. for pharmaceuticals than the rest of the world. Companies invest in pharmaceutical advancements because they anticipate breaking into the US market. That cookie is what fuels investment in the R&D that is needed for these miracle drugs. Pharma is creating a ton of miracle drugs, and without that that incentive to break into the US market, that there's going to be a lot less investment in R&D for these miracle drugs. And the second reason I'm not a fan is it is an additional layer on a very multi-layered sclerotic system of drug pricing that we have in the United States. If you go back and you look at things like Medicare, the fact that the government is a payer, and the layers of legislation that have been introduced to try to attempt to control drug prices, all they've done is distort the market and make it worse and worse. So you go back, you can look at the Medicaid drug rebate program, the MDRP, you can look at the 340B program, you look at the way that Part D was structured with the rebates. All of these are layered on layers to try to correct a previous problem that has further distorted the market, that has driven up list prices. And there's this huge gap between the list prices and what we actually pay for medications. And it's really difficult to measure that gap. I don't think the answer is another layer of bureaucratic administration on top of this. I think the answer is going back to basics, peeling back these layers and seeing how we can have the market actually give us what the true price, the true clearing price is for the certain medications.
But you're negotiating the price. I mean, you're not saying, I mean, obviously, you don't want to get the companies out of business because they save lives, right? I mean, a lot of the drugs in oncology, what I do is have transformed how we take care of people. But at the same time, is there a negotiation window? Because isn't that what happens in Europe? I mean, don't like if you're a company, you come in direct to market in the UK, let's say you have to work with the NHS to negotiate this. I guess in principle, I see how this is not free market, but at the same time, um, with medications that could be life-saving, it's very difficult to know how elastic the situation could be, right?
Right.
Because, I mean, you don't have a lot of choice. If you need this drug because you've got cancer, your elasticity is very different than if you have something, you take a vitamin, whether it's good to have or not.
Totally agree. There's a couple points there. Is one is it's not a negotiation. The government doesn't negotiate; it sets a price, right? The company can't come back and say, "Well, maybe we could do this." The government sets a price, and that's how it works in Europe as well, right? So in the UK, you have the NICE program where they essentially measure what they expect the benefit of the drug to be, and they say this is the price we're going to pay. It's the same that goes in Germany and a lot of the other European countries. Is they set a price. It's not a negotiation. So price setting tends to distort markets further. To your point about high cost drugs, I totally agree. We need high cost drugs covered for patients, but this is why you have a third party payment system. And I disagree a little bit with my colleagues who are more hardcore Austrian libertarian economics, is that I think a third party system is necessary for things like high priced drugs, right? If I get cancer, that's the reason I have health insurance, is to cover the cost if I have cancer. I don't need health insurance if I need Advil, right? I can go get that over the counter. And a lot of medications, they have generic forms that are really cheap. You can get a direct primary care plan that covers a lot of your generic medications
Yeah.
that you essentially pay out of pocket. And so for the high price cancer drugs, absolutely. That's why you have third party payments. That's why you have insurance. That should be covered by insurance. But for your standard day to day drugs, for your things like even your monthly blood pressure medications, a lot of these pills are a penny a pill on generic, right? They're extremely affordable, and the fact that we have this third party payment system for these medications is really what's distorting the price. Another point on the oncologic medications, there's the program called the 340B drug discount program that massively distorts the price signals for
Agreed.
oncologic medications, right?
Agreed.
We could probably do a whole other podcast on the 340B program. I've written extensively on
Actually,
it.
actually, I want to. I've been trying to find, maybe you're the right person for this. I've done this about 3 years ago, a 340B, and I think it's time to refresh for this. So we'll have to do another one on this because I've been trying to figure out who would be the best person for the 340B. A lot of people don't understand it, frankly.
Yeah, it's very complicated. It's highly nuanced, but it's a huge influence. It is the second biggest drug pricing program after Part D, right? It reached about
Yeah.
$65 billion last year. So again, we're talking about how we finance the safety net. 340B is a big part of that. Would love. I could easily spend an hour talking to you about 340B.
You will. We will. We're gonna plan
Perfect.
this. I know how tough your schedule is, but we will. We have to do it. So this will be like, I call these like the green episodes. We can always air them anytime.
Great. Yeah, I'm happy to talk about find time to talk about 340B. My wife's sick of hearing me rant about it. So the more other people I can rant, it just spares her.
I think a lot of people genuinely don't understand well. I also think the Affordable Care Act, a lot of people, um, it's interesting. You said something earlier. The Affordable Care Act turned out to be not so affordable. And I think you brought in a few points that are very worthwhile listening to and contemplating upon. But because we live in such a politicized environment, if you criticize the Affordable Care Act, you become somebody who really don't want to provide access to people who need medical care. How do you answer this? How do you try, I guess, how do you try to have civil discourse and conversation at the same time not coming across as insensitive? And frankly, from all people, you should be commended as the least insensitive person because you could easily double your salary. And by the way, Anthony, we all know your salary now. The entire world knows how much you make, and
Right.
I'm expecting you to buy all of my books. And but the I'm trying to say you have to discuss this conversation without coming across that, well, I really don't care if people don't get covered or not. At the same time, if you criticize the ACA, you are viewed as somebody who doesn't really care about people getting access to medical care.
Yeah, there's definitely a subset of the population that if you criticize any policy within the ACA, you'll be viewed as partisan, and just wanting to undo, some of the work because you happen to fall on the other side of the political aisle. We had a very interesting discussion. As part of the ACA, there is a ban on physician-owned hospitals. So it was inserted into the ACA by the American Hospital Association to get their support for the bill. I think that the ban on physician-owned hospitals is terrible. It is anti-competitive. It has helped fuel this hospital consolidation. And so I've been advocating just, if we look at specific policies within the ACA, where could we do better? What could we leave alone? And I think the ban on physician-owned hospitals is something where we could do better. And so I've brought this up. I brought this up with organized neurosurgery in policy groups. And if you frame it as reforming the ACA, you instinctively get people who have a visceral reaction and will oppose you.
Right.
But if you start out by saying, I want physicians to own hospitals, and you don't mention that it is actually part of the ACA, then it's easier to get people on your side. So that's just how I tend to approach policy is say like, hey, there's this thing, there's this rule that is distorting the market, that is making it worse for us as physicians, is making it worse for our patients. Here's how I think this rule could be better. Let's put the politics aside. Let's see how we can get to the point where we can agree on how we can make this better for our patients.
What's your how? I mean, we talked about Twitter. I want to maybe a few minutes. social media discussions and conversation and so on. You're obviously vocal on it. You spend some time on it, and you go back and forth. How, what's your assessment of where we are in terms of social media dialogue and conversations when there is always this divide on views?
I actually I don't mind it. Yeah, as you mentioned, I was somebody attempted to publicly shame me by posting my salary for
How
all
did
to
they
see.
find your salary, by the way? Is that
Well,
public?
so yeah, it is. I'm an employee of the state of California, technically, since I work for the UC system. So my
I
salary
see.
is publicly available. Um, but I actually that ended up being a positive experience. I had a lot of people, such as you, reach out and contact me. I had a lot of people saying they supported me. And despite the vitriol that is out there on social media, there's actually a lot of good interactions that I've had with people. People even on the complete opposite side of the aisle. There's some people on there who push back against a lot of my ideas, make me take a serious introspective look at why I believe the thing I believe, make me really rationalize through the economics and the philosophical arguments behind these things. And I think I've come to a good middle ground with quite a few people. The people that go on there and just spew venom and vitriol at me, whatever. That's their own problem. That says more about them than it does about me. I had another faculty member call me some very nasty names, but that's his problem, not mine.
Do you, in your exp when you worked with, what was your role with Bill Cassidy when you worked with him or for him?
Healthcare policy fellow. Just I was there only there
Yeah,
for a little over a month.
yeah. I mean, have you ever considered running for office?
No, my wife
Okay,
would
I'm
kill
not
me.
the first person who asked you that. Am I the first person who asked you that?
You're not. My
See,
district. I am a
I know future
reg.
politician when I see one.
No. I'm a registered Republican, and my district is D plus 27. So I don't think that's happening anytime soon. And my wife would kill me.
And you live in California.
Exactly.
Yeah. Well, is there anything else you want to tell viewers and listeners pertaining specifically on the Medicaid? We're going to do something else on 34AB because I think it's more, but I mean, I actually understand more now since I've had the conversation, but is there anything else like misconceptions, people that you see that they don't really understand certain elements that you want to clarify so they can really understand what the system looks like when they have when they try to have an intelligent conversation?
Yeah, I think it's important to critically look at Medicaid and see what it does provide. I have a lot of people, talk to me about Medicaid is better than no insurance. And sure, I'll grant them that, despite the fact that there were actually two large randomized trials that showed that for some healthcare outcomes, Medicaid is actually no better than having no insurance. But I will grant them that Medicaid is probably better than no insurance, but I don't think Medicaid is better than commercial insurance. But there are people out there that would argue that the cost sharing portion of Medicaid makes it better than commercial insurance. I think there's a lot of evidence out there that Medicaid patients lack access to care. They get more of their surgery through the ER rather than through elective means. There's secret shopper studies showing that it's really difficult for Medicaid patients to get subspecialty appointments compared to commercial insurance. Um, and I don't think people really realize how bad the access issue really is in some areas of the country. For example, I know areas where the wait time for simple hip or knee replacement surgery is over 2 years for Medicaid patients. Those same that same area has a wait time of a few weeks for commercial insurance. I know areas where a cataract surgery wait time for Medicaid patients is 5 years, right? I mean, if you give people the option to pay out of pocket or wait 5 years, I guarantee you most people will just pay out of pocket, right? But what happens when we have Medicaid, when we have this price setting, is you don't pay with money, but you pay with other means such as wait times or other things that end up costing not dollars, but end up costing you because you're not getting the care that you need.
And that's if you get the surgeon or the office to agree to see you being part of Medicaid. I mean, there are just many offices that just flat out say it's not gonna be
Yeah,
seen.
exactly. And the MCOs can have some closed networks, which I think does hurt people. But again, if you have a competitive market with people able to direct their healthcare dollars where they want them, I really think um, people have the wherewithal to make their own choices. And so, in the larger picture, I reject paternalism in healthcare. There's some people I talk to who say, we have to cover these things because otherwise people won't, get preventative care, or et cetera, et cetera. But people have agency. People have the ability to take ownership of their own healthcare. And I think just making it so there's no cost sharing or making sure that we, use the heavy hand of the state to nudge people into the right direction, I don't think is the right method. I think we should empower people to make their own decisions, let them take control of their healthcare. And I think overall, on aggregate, we're going to get better results than we will by trying to direct and nudge people the way we want them to go.
One of the things, and we'll finish with this, but I'll have to say one thing I did not think about that really intrigued me a lot, and you put that initially on Twitter, and then you mentioned earlier, I didn't think about that, whatever the state is paying and subsidizing and putting money into each individual Medicaid patient, give that money to this individual, have them bear the responsibility. I mean, we have people responsible for a lot of things. Take that money, it could be seven, $8,000 a year per individual, and you purchase your own health insurance. Maybe take the rest like in an HSA account. I, I mean, I mean, this is. I haven't heard anyone say it this way. Did you just come up with this, or I mean, I haven't
No,
heard it really. I haven't
yeah.
heard anyone say that.
Yeah, there's some other people who are talking about it. Indiana is, like I said, Medicaid is state by state. Indiana, I think, is doing it right. They have a DPC option within Medicaid. There are bills in Washington. Dan
Yeah.
Crenshaw is a co-sponsor of one, which allows a HSA DPC benefit in Medicaid. So it is being talked about. There are voices out there. Something else that I think that would help with that we didn't really touch on is the churn in Medicaid. Right. So if you go in and out of eligibility, you can lose Medicaid from month to month and then regain eligibility, et cetera, because it's essentially a 100% tax once you go out of eligibility. You go from having everything covered to having 0% covered. And so there's some ways you could also turn premium support to reduce churn. So if your Medicaid benefit is paying for your healthcare plan and you go out of eligibility, you can still keep that plan. And then when you go back into eligibility, you just get more of a premium support, et cetera. And again, it's really about empowering patients to just make their own decisions and take control of their healthcare.
This was amazing. I enjoyed every minute of it. Dr. Anthony DiGiorgio, thank you so much for coming on the show.
Thanks for having me. Pleasure's been mine.